abbreviated overviews of the various types of randomization schemes that can be employed in a clinical trial. Simple randomization is probably what most of us are familiar with. It's analogous to the coin toss again. It's just a complete randomization. Each time you toss the coin is independent of the last time you tossed the coin. So it doesn't matter if you got a heads or tails the last time. This next flip is totally independent and has a 50-50 chance of either heads or tails. The advantage of having a simple randomization scheme where the last assignment doesn't tell you anything about the next assignment and the actual probability of the treatment assignments stays fixed from assignment to assignment, from coin toss to coin toss, is that each assignment is completely unpredictable. The fact that a patient was assigned to treatment A yesterday will tell you nothing about what this new patient is going to be assigned to. And in the long run, if you have enough patients, it will equal out. If you have a truly scientifically designed randomization process and you use a simple randomization scheme, the number of patients assigned to each group should be about equal, assuming you have large enough numbers. So the risks associated with a simple randomization procedure is that you may indeed have imbalances. These imbalances could be related to the number of patients assigned to each treatment group. For example, you could end up in a trial of 100 patients with 40 assigned to one group and 60 assigned to the other group when your ideal was a 1-to-1 allocation with 50 patients in each group. And that in itself will lower the statistical power, or could lower the statistical power associated with your clinical trial. Also, you can have an imbalance related to important confounding factors. If there are prognostic factors associated with the outcome, and in a simple randomization scheme, the chips are going to fall where they may. So you could just by chance have more people with severe disease assigned to one group than the other, or more women assigned to one group than the other. So there's no control on the characteristics of the patients by treatment group. And if you have large numbers of patients in a trial, that's not such a problem because your large numbers favor the probability that you really will get comparable distribution of potential confounding factors across the treatment groups. But with small numbers, you're more likely to run into imbalances. And again, that can lower the statistical power of your trial. And even if these imbalances, either in the number of patients or the types of patients or both, don't really affect the results of your trials. They really are not too severe in terms of numbers, and the factors that the groups are imbalanced on really don't have an association with the outcome. It still can diminish the credibility of your results. It can make people question things. Well, why didn't they have equal numbers in both groups? Or more commonly, oh, well, of course, they had the sickest patients were in treatment group A, so that's why treatment group B looked better. And sometimes you can never really address those credibility issues fully, and they can really undermine the results of your trial and give people reasons not to accept the results. As I've referred to before, these risks are inversely associated with the number of participants. The more participants you have in a trial, the more that the properties of probability are going to be working in your favor. So how have clinical trialists and biostatisticians addressed this issue? Well, they've imposed restrictions to the randomization scheme to ensure balance across important factors in the design of experiments. So, and somehow there's a constraint added to produce the expected assignment ratio in the example we've been using 1-to-1 according to time that the study is being going on, or on specified covariates such as severity of disease or gender or clinic. And the two primary maneuvers that are used in this restricted randomization are blocking and stratification. And I'll go over each one of them separately. First, we'll start with blocking. So let me just tell you what blocking is before I tell you why we do it. A block, if you wanted to find a block, is a list of treatments that achieves the treatment assignment ratio. Again, we're sticking with that example of 1-to-1. So a block of 2 would be an A and a B, that we achieve the ratio of 1-to-1. If we used a block size of 4, that means that a block would have 2 A's and 2 B's in it. And we talk about permuted block designs, which means every possible way you could list those 2 A's and 2 B's. And you see listed out on the slide is the 6 possible ways you could order 2 A's and 2 B's. You can have AA, BB, AB, AB, and I'll let you read the rest for yourselves. But that's the list of permutations of the order of the treatment assignments inside a block of 4 for a 1-to-1 treatment assignment. Another important point is that the size of the smallest possible block to use is the sum of the integers defined in the treatment allocation ratio. So you can't meet the treatment allocation ratio if you have a block that is smaller than the sum of the integers. So I think an example illustrates this best. If the allocation ratio is the sum for a one-to-one treatment assignment, rest for yourselves, but that's the list of permutations of the order of the treatment assignments inside a block of 4 for a one-to-one treatment assignment. Another important point is that the size of the smallest possible block to use is the sum of the integers defined in the treatment allocation ratio. So you can't meet the treatment allocation ratio if you have a block that is smaller than the sum of the integers. So I think an example illustrates this best. If the allocation ratio is 1-to-1, the smallest block size is 1 plus 1 is 2. That's the smallest block you can have to get a 1-to-1 ratio. So if you have a different allocation ratio, say 2-to-1, the smallest possible block size is 3, because you'd have to have 2 A's and 1 B. And if you wanted to go and use larger block sizes, and I'll discuss reasons for using different block sizes in a few minutes, the larger block sizes need to be multiples of the smallest one. So in order to meet the treatment allocation ratio of 2-to-1, the smallest block size you can have is 3. The next one is 6, because that is a multiple of the smallest block size, and it goes up accordingly. So because within a block size of 6, you could meet that allocation ratio of 2-to-1. You could have 4 A's and 2 B's. Now, if you have a block size of 7, that wouldn't work, or even a block size of 8. You couldn't meet that treatment allocation ratio within that block size. So the larger block size are multiples of the smallest one. And then when we apply this blocking principle and use blocks of treatment assignments, what we really do is produce all possible permutations of the block, similar to how I have listed as the second sub-bullet under the first bullet. We list all the possible ways a block of 4 could be ordered. And then when we go to develop a randomization scheme or a list of the treatment assignments, what we do is randomly choose those block sizes, randomly choose from those permutations of a block size of 4. So I think the example we'll come upon in a few slides will help illustrate this point. So why do we do this? It seems sort of confusing, and if it does seem confusing when you first look at this, this is common, that blocking is one of the more difficult, simple concepts that we deal with. Once you get it, it's very clear, but just that first time understanding exactly what blocking is may take some quiet moments alone looking at it. But the reason we bother to do this is that it ensures balance in the treatment assignment ratio over time. And this makes sense, right? Because if we're using that block size of 4, that means after every 4 patients, even if we have a sample size of 400, after every 4 patients, we're ensured that we've met the allocation ratio, that 2 have been assigned to A and 2 to B. As we go along in the trial, we can't have long runs of A's or long runs of B's that you might have in a simple randomization design that would be associated with time because it takes time to accrue patients to a trial. You can't have that problem if you use the block size. You'll only have runs of one particular treatment assignment, the longest run possible within a particular block size. And you can see with a block size of 4 in a 1-to-1 allocation ratio, the longest possible run of a treatment is 2 for 2 patients. So how do you figure out how many permuted blocks do you have with a particular block size? Well, when you start with small block sizes, it's fairly easy. So if you have the allocation ratio is 1-to-1, right? If the size of the block is 2, the number of possible blocks you can have is 2. It's AB and BA. And the way you can figure that out is to write them down, or you can use this multinomial coefficient you see illustrated at the bottom of the slide in blue with the factorial signs. Now don't be scared of this formula, it's quite simple. So again, if you are back to a block size of 4 with the 1-to-1 allocation ratio, I showed you on the last page and have listed out all the possible blocks, and that is 6. But we can come up with that number 6 by using the multinomial coefficient. So the numerator is the factorial of 4. You see that 4 exclamation point, which translates to 4 times 3 times 2 times. So the numerator is the factorial of 4. You see that 4 exclamation point, which translates to 4 times 3 times 2 times 1. And then the denominator is the number of each kind of thing. So in this example, in a block size of 4, we're going to have 2 A's and 2 B's. So the R, we have an R1 and an R2, and both of them equal 2 in this case. So you can see that the 4 factorial is divided by 2 factorial times 2 factorial, and you get the number of possible permuted blocks for a block size of 4 is 6 blocks. And I'll let you go through that on your own for a block size of 6, where it starts to get more complicated and you don't want to have to sit down and write out all possible blocks, in this case 20, and you'd rather be able to figure that out more easily using this shortcut of the multinomial coefficient. So once we've decided that we're going to have a blocked randomization design, commonly referred to as permuted blocks, and this is probably one of the most common features of a randomized clinical trial design, that most trials do use blocking, but there are some considerations when implementing a block design. First, you have to use the same allocation ratio throughout the trial. You can't modify your allocation ratio as you go along, and we'll see an example of that when we talk about adaptive randomization. So if you're going to use blocking, you've bought into the fact that your allocation ratio is going to be the same throughout the trial, which again is very common not to change the allocation ratio. Second, it's important to understand that block sizes and information about the block sizes used in a clinical trial are really on a need-to-know basis. They, in general, shouldn't be written down in the protocol that the investigators are going to be looking at, because it gives you a hint about how the randomization scheme is going to work. And if you know the block size, then you'll start to be able to predict what the next assignment is. And that's one of the whole points of randomization, is to make the next assignment unpredictable, so investigators or people won't be influenced by that knowledge about who to enroll in the trial or when to enroll them. So I've heard people say, well, they see the block size written down in the protocol, you really shouldn't write it down there. Now, there should be separate documentation of the treatment assignment scheme and how it was generated, but generally the details in the protocol should be limited to those that the clinician needs to know in order to execute the protocol and be knowledgeable about the general experimental design. Now, one of the tricks that we use to maintain that lack of knowledge about upcoming treatment assignments is to use more than one block size, because then the overall sequence of how treatment assignments are allocated is going to appear to be more random. If you use a standard block size of 2 in the 1-to-1 allocation ratio, people are going to be able to start figuring that out, that if the first assignment was an A, the next one's going to be a B. And if they know the block size, then they'll know that block's complete. And then they're back in the next, when the next block opens up, they're back to not knowing whether it's going to be an A or B. But once that third assignment is issued, they're going to know the fourth assignment. And it gets a little bit more complicated with larger block sizes, but Nonetheless, it takes away from the unpredictability aspects of randomization. And so the way we try to deal with that is to use more than one block size so that the treatment assignments appear to be more like a simple randomization scheme and are less likely to be predicted accurately. And this is especially important in unmasked trials, because if you know the treatment and are likely to be predictable, that the treatment assignments appear to be more like a simple randomization scheme and are less likely to be predicted accurately. And this is especially important in unmasked trials, because if you know the treatment in a masked trial and you know which treatment's going to come up, A or B, and it's masked, well, if it's effectively masked, you still don't know that much. You know that it will be a different treatment, but you don't know which treatment it is. If it's a unmasked trial and you start to figure out the block sizes, then you're going to know the actual treatment that's going to be administered to the next patient, or have a good idea. And certainly that opens the door to more selection bias creeping into the trial, or again, back to that confounding by indication. Okay, so what are some of the benefits and risks associated with blocking? Well, some of the advantages associated with blocking are that it helps to guarantee overall balance, especially in smaller trials. So you're more likely at the end to get equal numbers in both groups. It also protects against time-related changes that may influence your clinical trial. That could be, those changes could be in the composition of the study population. So if you start with more severe patients and get to less severe patients enrolled in the trial as the trial goes on, if you have blocking, you're more likely to have equal representation of those different types of patients in both groups. And those kind of changes, you know, a lot of things can change over the course of a trial. The study population, you may have some new data collection procedures, or new instrumentation that is implemented in the course of the trial that you'd like to have used equally in both groups. And there could be other forces outside of the trial that may influence outcomes that you would like those external forces to be equally distributed across the treatment groups. And by ensuring that the allocation ratio is met as you go along in the trial, blocking protects against some of these time-related changes. Also, if you have a case where a trial is stopped early, either because of efficacy measures, you've found a good treatment and you don't believe it's ethical to continue, or safety reasons, that you're more likely to have balanced groups because you have this blocking that institutes balance every so often as you go along, and that leads to a more powerful analyses. The disadvantages of blocking, as I mentioned before, is that they can facilitate the prediction of future assignments. If you figure out the block size, you can start to figure out what is likely to be the next assignment. And that disadvantage is more problematic in unmasked trials, or trials that are poorly masked, that people can figure out the treatment assignments. So now I'm going to go on to the second common maneuver that's used to restrict randomization, and that is stratification. And stratification is used to ensure balance in the treatment groups across groups that can be specified before randomization. So by imposing stratification, we can ensure that the treatment assignment is met within a subgroup of the population, and those subgroups are commonly clinic, gender, or some measure of disease severity. So if we stratify by clinic, then we can ensure that at each clinic we are going to meet the allocation ratio. And you can imagine that could seem like intuitively an important thing to do, that if you have clinics scattered across the country or indeed the world, that there may be plenty of population infrastructure issues that influence the outcome for those patients just as much as a treatment may. So you want to ensure that you're balanced in your treatment assignment within each clinic so that you have a fair comparison of the treatment assignments, and those external factors associated with the clinic don't bias your comparison. Generally, if you're going to use stratification, it should be reserved for subgrouping variables that are considered to be strongly related to the outcome, the primary outcome for the trial. They can either be a strong confounder, sort of as we've talked about before, that some prognostic factor that strongly predicts whether you're going to have a good or bad outcome, or
ሶሪ ሲማ ያው ሶሪ ያልኩሽ የአንቺ ኦፒኒየን ተቃራኒ ስለሆነ ነው። ምናልባት ሙሉውን አይተሽዋል እያየሽው እንደነበር ስለነገርሽ እዛ ቦታ ላይ የቸሬም ሆነ የቴክስት ስፔሻሊ የቸሬ ኢሹ ኦድ ነበር ለእኔ ማለት ማስታረቅ እንደሚችል ለማሳየት ከመሞከር ባሻገር የግለሰቦቹን ፋሻል ኤክስፕሬሽን እንኳን መረዳት ያልቻለበት ኢሹ ነበር። ፕሪስቴጅ ፕሪፓሬሽን ያስፈልግ እንደነበር አምናለሁ። ይሄ ሰውዬ መድረክ ላይ ከወጣ በኋላ እሷን እንዲያገኛት አይነት ስታፍ ነው የነበረው። ይህንን ኢሹ በእርግጠኝነት ፓስተር ቸሬም ከሰይፉ ጋር አውርተውበት እንዳይሆነ ወይም ደግሞ ሊያወሩበት እንደሚችሉ ይሰማኛል። እንደው ሳይሰማ ቀርቶ እንኳን ቢሆን ኖ መጀመሪያ ማውራት ይኖርባቸዋል አይነት ኢሹ ሊያነሳ ይገባ ነበር። ሁለቱንም በግል አስቀድሞ ማግኘቱን እንደ መንገሩ መጠን ሁለቱ በጋራ የሚያገኙበት እና ፕሪ ስቴጅ ፕሪፔር አድርገው እርስ በርስ የሚያወሩበት መንገድ መፍጠር ይቻል ነበር። ምናልባት የግለሰቡ ፌሻል ኤክስፕሬሽን ላይ አይተሹ ከሆነ አንገር አለ፣ የሆነ ቁጣ ነገር መናገር ፈልጎ መናገር የማይችለው አይነት ስሜት፣ ይሄ የታመቀ አይነት ነገር አለው እና ቢችል በዛ ቅጽበት ከዛ ቦታ ቢሄድ ደስ በሚለው ደረጃ አንኮንፈርታብል በሆነበት ሁኔታ ነው ሁለቱም ስለ ይቅርታና ስለ ሪካውንሲሌሽን ሲያወሩ የነበረው እና ይሄ ለእኔ ሙያዊ አልመሰለኝም። እንደውም ፓስተር ቸሬ ራሱ የድራማው አንድ አካል እስኪመስለኝ ድረስ ከዚህ በፊትም ሁለት እንዲህ ፐብሊክ የወጡ ጋብቻ ኢሹዎች ላይ የህፃን ማን ነበር ስሟ ብቻ የተደፈረችው ህፃን ወላጆችም ላይ ፕላስ ደግሞ የአንድ ዘፋኝና አርቲስት እንትንም ላይ የነበረውን ሮል አይቼዋለሁ እና ሞር ኢግኖራንት የመሆንና ከግለሰቦቹ ፐርሰናል ኢሹዎችን ፐርሰናል ሳይኮሎጂካል ኮንሰፕቶችን ትቶ ይሄ ሶሻል ሪስፖንሲቢሊቲ ላይ ሶሻል ቫሊዩ ላይ ፎከስ ያደረገና ኢንዲቪዥዋል ፍሪደማቸውንም የነጠቀ መስሎ ተሰምቶኛል እውነቱን ለመናገር እና የሆነ ሰዓት ላይ ቀረጻው እንዲቆም ራሱ መደረግ ይኖርበት ነበር ብዬ አምናለሁ። እንደው ቀረጻው እንኳን ከተጠናቀቀ በኋላ አለመተላለፍ ይኖርበት ነበር። ምክንያቱም ልጁ የነበረበት ስሜት በቃ በግልጽ የሚታይ ነው። የሆነ ነው ብቻውን መፈንዳት የሚፈልግ አይነት ስሜት ውስጥ ነበር የነበረው። እሷን በጣም ዲስግሬስ እንደተደረገች ነው ሳይ የነበረው እና ያንን ዲስግሬስፉልነስ ወደ ሚዲያ አውጥቶ ፐብሊክሊ መልቀቁ አግባብ አልነበረም። እንዳይለቀቅ የቻሉትን ማድረግ የሚችሉ ነበረ የግለሰቦቹን ስብዕና ከመጠበቅ አንጻር። ያ በጣም አስከፍቶኛል። የእኔ ኢንሳይት ይሄ ነው። ሶሪ ሲማ ያው ሶሪ ያልኩሽ የአንቺ ኦፒኒየን ተቃራኒ ስለሆነ ነው። ምናልባት ሙሉውን አይተሽዋል እያየሽው እንደነበር ስለነገርሽ እዛ ቦታ ላይ የቸሬም ሆነ የቴክስት ስፔሻሊ የቸሬ ኢሹ ኦድ ነበር ለእኔ ማለት ማስታረቅ እንደሚችል ለማሳየት ከመሞከር ባሻገር የግለሰቦቹን ፋሻል ኤክስፕሬሽን እንኳን መረዳት ያልቻለበት ኢሹ ነበር። ፕሪስቴጅ ፕሪፓሬሽን ያስፈልግ እንደነበር አምናለሁ። ይሄ ሰውዬ መድረክ ላይ ከወጣ በኋላ እሷን እንዲያገኛት አይነት ስታፍ ነው የነበረው። ይህንን ኢሹ በእርግጠኝነት ፓስተር ቸሬም ከሰይፉ ጋር አውርተውበት እንዳይሆነ ወይም ደግሞ ሊያወሩበት እንደሚችሉ ይሰማኛል። እንደው ሳይሰማ ቀርቶ እንኳን ቢሆን ኖ መጀመሪያ ማውራት ይኖርባቸዋል አይነት ኢሹ ሊያነሳ ይገባ ነበር። ሁለቱንም በግል አስቀድሞ ማግኘቱን እንደ መንገሩ መጠን ሁለቱ በጋራ የሚያገኙበት እና ፕሪ ስቴጅ ፕሪፔር አድርገው እርስ በርስ የሚያወሩበት መንገድ መፍጠር ይቻል ነበር። ምናልባት የግለሰቡ ፌሻል ኤክስፕሬሽን ላይ አይተሹ ከሆነ አንገር አለ፣ የሆነ ቁጣ ነገር መናገር ፈልጎ መናገር የማይችለው አይነት ስሜት፣ ይሄ የታመቀ አይነት ነገር አለው እና ቢችል በዛ ቅጽበት ከዛ ቦታ ቢሄድ ደስ በሚለው ደረጃ አንኮንፈርታብል በሆነበት ሁኔታ ነው ሁለቱም ስለ ይቅርታና ስለ ሪካውንሲሌሽን ሲያወሩ የነበረው እና ይሄ ለእኔ ሙያዊ አልመሰለኝም። እንደውም ፓስተር ቸሬ ራሱ የድራማው አንድ አካል እስኪመስለኝ ድረስ ከዚህ በፊትም ሁለት እንዲህ ፐብሊክ የወጡ ጋብቻ ኢሹዎች ላይ የህፃን ማን ነበር ስሟ ብቻ የተደፈረችው ህፃን ወላጆችም ላይ ፕላስ ደግሞ የአንድ ዘፋኝና አርቲስት እንትንም ላይ የነበረውን ሮል አይቼዋለሁ እና ሞር ኢግኖራንት የመሆንና ከግለሰቦቹ ፐርሰናል ኢሹዎችን ፐርሰናል ሳይኮሎጂካል ኮንሰፕቶችን ትቶ ይሄ ሶሻል ሪስፖንሲቢሊቲ ላይ ሶሻል ቫሊዩ ላይ ፎከስ ያደረገና ኢንዲቪዥዋል ፍሪደማቸውንም የነጠቀ መስሎ ተሰምቶኛል እውነቱን ለመናገር እና የሆነ ሰዓት ላይ ቀረጻው እንዲቆም ራሱ መደረግ ይኖርበት ነበር ብዬ አምናለሁ። እንደው ቀረጻው እንኳን ከተጠናቀቀ በኋላ አለመተላለፍ ይኖርበት ነበረ። ምክንያቱም ልጁ የነበረበት ስሜት በቃ በግልጽ የሚታይ ነው። የሆነ ምንድን ነው ብቻውን መፈንዳት የሚፈልግ አይነት ስሜት ውስጥ ነበር የነበረው። እሷን በጣም ዲስግሬስ እንደተደረገች ነው ሳይ የነበረው እና ያንን ዲስግሬስፉልነስ ወደ ሚዲያ አውጥቶ ፐብሊክሊ መልቀቁ አግባብ አልነበረም። እንዳይለቀቅ የቻሉትን ማድረግ የሚችሉ ነበረ የግለሰቦቹን ስብዕና ከመጠበቅ አንጻር። ያ በጣም አስከፍቶኛል። የኔ ኢንሳይት ይሄ ነው።
or some factor that is actually even an effect modifier that the treatment strongly predicts whether you're going to have a good or bad outcome. Founders sort of are considered to be strong. If you're going to use stratification, it should be reserved for subgrouping variables that are considered to be strongly related to the outcome, the primary outcome for the trial. They can either be a strong subgrouping associated with the clinic. Don't bias your comparison. Each clinic so that you have a fair comparison of the treatment assignments, and those external factors associated with the clinic don't bias assignment with infrastructure issues. That influence the outcome for those patients gendered across the country meet the allocation ratio. And you can imagine that could seem like intuitively an important thing to do, that if you have clinics scattered across the country or indeed the world, that there may be plenty of population infrastructure issues that influence the outcome for those patients just as much as a treatment may. So you want a world that there, and you can imagine that could seem like, then we can ensure commonly clinic, gender, or we can ensure that the treatment assignment is met within a subgroup of the population, and those subgroups, and that is out the treatment assignments. So now I'm going to go on to the second common maneuver that's used to restrict randomization, and that is stratification. And stratification is used
ከረንትሊ ግን እነሱ እያወሩ ሳይሆን እየመሰለኝ ያለው ከእነሱ ጀርባ ያለው ሰው እያወራ ነው የሚመስለኝ። እንዲያድርጓት ምናምን የሚባል ነገር ስላለ እሷ በቃ ምንድን ነው ይቅር ባይ አይነት ስታፍ ሆና ነው የመጣችው። ዘንድ ደግሞ እሱ ደግሞ እንደዚህ ስላደረክ እንደዚህ ስለተጎዳህ ምናምን ተብሎ ከኋላ ብዙ አይዞ ባይ ከጀርባ ያሉ ሰዎች አሉና እሱም እያወራ ያለው የእነሱን አቋም ነው። እሷም እያወራች ያለችው የሌላውን የፐብሊክ አቋም እንጂ የራሳቸው አቋም ያላቸው አይመስለኝም።
used to ensure balance in the treatment groups across groups that can be used to restrict randomization so that people can figure out the treatment assignments. So now I'm going to go on to the second common maneuver that's used to restrict randomization, and that is stratification. And stratification is used to ensure balance in the treatment groups across groups that can be specified before randomization. So by imposing stratification, we can ensure that the treatment assignment is met within a subgroup of the population, and those subgroups are commonly clinic, gender, or some measure of disease severity. So if we stratify by clinic, then we can ensure that at each clinic we are going to meet the allocation ratio. And you can imagine that could seem like intuitively an important thing to do, that if you have clinics scattered across the country or indeed the world, that there may be plenty of population infrastructure issues that influence the outcome. Clinics scattered across the country or indeed the world, and you can by clinic, then we can ensure that at each clinic, if you have clinics scattered across the country or indeed the world, that there may be plenty of population infrastructure issues that influence the outcome for those patients just as much as a treatment may. So you want to ensure that you're balanced in your treatment assignment within each clinic so that you have a fair comparison of the treatment assignments, and those external factors associated with the clinic don't bias your comparison. Generally, if you're going to use stratification, it should be reserved for subgrouping variables that are considered to be strongly related to the outcome, the primary outcome. Reserved, and those external factors associated balanced in your treatment assignment with infrastructure issues that influence the outcome. Clinics scattered across the country or indeed the world, that there may be plenty of population infrastructure issues that influence the outcome for those patients just as much as a treatment may. So you want to ensure that you're balanced in your treatment assignment within each clinic so that you have a fair comparison of the treatment assignments, and those external factors associated with the clinic don't bias your comparison. Generally, if you're going to use stratification, it should be reserved for subgrouping variables that are considered to be strongly related to the outcome, the primary outcome for the trial. They can either be a strong confounder, sort of as we've talked about before, that some prognostic factor that strongly predicts whether you're going to have a good or bad outcome, or some factor that is actually even an effect modifier, that the treatment effect works differently in different subgroups of the population. So practically, what stratification requires is a separate treatment assignment schedule for each stratum in a stratified randomization scheme. So if you have 3 clinics, that really means if you're going to institute a randomization scheme that's stratified by clinic, that you'll need 3 different treatment assignment lists. So here's an example of both stratification and blocking. So the example we're going to use here is for some type of treatment for breast cancer. So we have treatment A or B. Again, back to the 1-to-1 treatment allocation ratio. That's what our ideal is. And we're going to stratify it by 2 different factors. One is center. Is the patient coming to center X or center Y. We have two different centers. And then we're also going to stratify the treatment assignment based on the patient's postmenopausal status. Is this someone who has gone through menopause or a premenopausal person? Into this stratified design, we're going to institute a block size of 4. So if you look at the table, you can see that the first row indicates the center, and then that sort of divides the actual table in half. Within each center, you can have postmenopausal or premenopausal women. So within each center, you have 2 types of women. So what's the treatment assignment going to be? Well, if you look under Clinic X for postmenopausal women, if we're using a block size of 4, potential first block could be the one listed there, where the first patient gets assignment B, the second patient assignment A, the third patient assignment B, and then the fourth patient assignment A. And as I talked about before when we were discussing blocking, voila, you end up with 2 A's and 2 B's after 4 patients. But notice that that's specifically within center X within postmenopausal women. So you actually have a separate list based on the stratification variables. So again, if you go to the right one column, we've got the list for premenopausal women who enrolled at center X. And when a premenopausal woman arrives at center X to be randomized, she is going to receive an assignment from that second string of A's and B's. So the first woman who fits that characteristic is going to get assignment B, the second woman will get assignment B, and the third and fourth woman will get assignment A, because that is the first block in that particular treatment assignment list for that combination of stratification variables. So I hope that's clear. Now, one point that may be a little hard to absorb at first is that if you stratify without blocking, there's really no point in stratifying, because what you end up doing is segmenting your population into small groups and then imposing a simple randomization scheme within those segmented groups. So you could even be more at risk for imbalances within those groups because you have smaller numbers of patients. So it's important to recognize that stratification alone is not a useful maneuver unless you're going to add blocking to ensure that there is balance over time and over assignments within each list that's defined by the stratification variables. So I'm going to go on to discuss some of the practical aspects of stratification. One thing that you should recognize is that you have to limit limited to a few variables. Once people practical aspects of stratification, one thing that you should recognize is that you have to limit it to a few variables. Once people are kind of aware of the benefits of stratification, they tend to think, wouldn't it be nice to have very homogeneous groups? But that can get you into problems to have too many stratification variables. So you want to pick ones that are highly related to outcomes, that are really important to control for in sort of a sense of confounding, and also ones that are logistically possible. You have to know the stratification variable status before you randomize. So you probably don't want to have as a stratification variable some interpretation of a blood test that takes a few days or a few weeks to get the results back, because you can't randomize someone until you know which list to use. So there's a logistical consideration that you need to have those data available at randomization. The typical ones that are used in multi-center clinical trials are clinic. That is almost universally considered an important stratification variable because populations and treatments do tend to vary quite widely by center. Sometimes in a surgical trial, because there's concern about the effect of different skill levels, the stratification variable will actually be on the surgeon involved in the trial, so that you can ensure that there's an equal allocation of what procedures were done by surgeon. You may also stratify by stage of disease if that is an important prognostic factor. If you have some measure of disease severity and what's the likely prognosis that you think is strongly related to the outcome, then you may consider that as a stratification variable. Probably there's more emphasis than there should be on demographic characteristics as stratification variables, but if you thought that it was important to ensure that you had the same numbers of people in treatment A and treatment B within subgroups based by gender or race or age categories, you could also stratify based on that type of characteristic. The problem that you can come across with having too many stratification variables, as you saw on the last slide, each combination relates in a separate list, is that you get too many strata and you can't fill up the blocks, and you actually are working against yourself, because if you have lots of strata and each one has a separate list associated with it and people are coming into the trial and filling up those blocks, what you may end up with is a lot of open blocks that didn't get completely filled. So a block size of 4 would be open if only 3 assignments were filled in that block. And if you have to merge together data from a lot of unopened blocks, you're likely to end up with an imbalance overall in the treatment group allocation. So you've sort of shot yourself in the foot. So stratification and blocking are really the two most common restrictive randomization features. And so the take-home points here are that blocking is very important in terms of ensuring that you maintain the design allocation ratio as you go throughout the trial and helps control for a number of things that can change over time, whereas stratification is related to baseline characteristics of the patient or where the patient is at, that you can control the balance of the treatment assignment, that it meets the design assignment within those subgroups of patients. And indeed, for stratification to be effective, you should also apply blocking. So the final type of scheme I'm going to talk about is an adaptive randomization scheme, and I'm only going to briefly review this. An adaptive scheme is a process in which the probability of assignment to the treatment, i.e. the allocation ratio, does not remain constant over the course of the trial, but is somehow determined by the current balance of participants in the trial or even the outcomes from patients enrolled in the trial. There are two common types of adaptive randomization schemes. One is based on minimization. After the first patient, the treatment assignment that yields the smallest imbalance is chosen. So instead of having stratum to ensure balance across important characteristics, in a minimization scheme, you can be balancing on a number of characteristics or prognostic factors. factors as you go on in the trial and ensure that you have balance as the trial goes on. So then if you have a patient with a certain set of characteristics that you have a relative lack of in a certain treatment group, their probability to be assigned to that treatment group would be greater, and you can combine several patient characteristics to do this. But the allocation scheme can't be determined in advance if you're using a minimization design, so you have to have some real-time, usually computer resources to be able to effectively institute a minimization scheme. In effect, you're sort of writing or generating the treatment assignment list as you go along to ensure balance across the treatment groups. Again, you have to decide what factors you want to balance things on and have data on those factors. Another type of adaptive randomization that relies more on outcome assessment is a play the winner design, where you change the treatment allocation to favor the better treatment based on the primary outcome. So if one treatment appears to be more favorable, you preferentially assign patients to the better treatment. You give them a greater probability of being assigned to the better treatment. To do this, you have to be able to evaluate the outcomes relatively quickly. So for the prior patient's outcomes to influence this next patient's treatment assignment, you have to have those data again to implement this kind of design, and therefore need to be able to evaluate the outcomes relatively quickly. And you can implement these designs in stages. So you might start with a fixed allocation ratio, and after you get to a certain number of patients, implement an adaptive ratio. Okay, I know this has been a long section. We've gone over simple randomization, restrictive randomization, and adaptive randomization schemes. Welcome. This session will cover cover the use of masking, also known as blinding, as a feature of a clinical trial. The purpose of masking is to reduce information bias. In a nutshell, it helps to ensure that we treat participants assigned to the experimental and control treatments the same throughout the trial and objectively evaluate their outcomes. I'm going to go to the outline of the lecture, and the first segment is going to be on the known as blinding as a feature of a clinical trial. The purpose of masking is to reduce. Welcome. This session will cover the use of masking, also known as blinding, as a feature of a clinical trial. The purpose of masking is to reduce information bias. In a nutshell, it helps to ensure that we treat participants assigned to the experimental and control treatments the same throughout the trial and objectively evaluate their outcomes. I'm going to go to the outline of the lecture, and the first segment is going to be on the definition of masking, the rationale for using masking in clinical trials, and some of the advantages and disadvantages. First, masking is synonymous with the term blinding, which you may be more familiar with, that is used in clinical trials to blind treatment. But for various reasons, I think masking is really a better term. What masking means is that the treatment assignment is not known after randomization. So it's important to recognize that this isn't about not knowing the treatment assignment before someone comes in, but it's after randomization. So someone's assigned a treatment, but it's masked, so they don't know which treatment it is, and that someone who doesn't know can be the patient. It can be the patient and the clinical personnel, or include people who are evaluating outcomes in patients. It can include data processors, analysts, and even the independent review committee and sponsors. And so we talk about single, double, triple, and quadruple masking, and I'll go over specific definitions of those in a few slides. But I do want to emphasize again, this is not the same as the the concealment of treatment assignment prior to randomization. That's what kind of design maneuver we use to prevent selection bias. So you can still have that early concealment in an unmasked trial, that once the person's assigned to the treatment, everybody knows what treatment that person's on. So that's a different thing than masking, which is once they're in the trial. So it's sort of an extension of that protection. Everybody knows what treatment, selection bias. So you can still have that early concealment in an unmasked trial, that once the person's assigned to the treatment, everybody knows what treatment that person's on. So that's a different thing than masking, which is once they're in the trial. So it's sort of an extension of that protection, and I'll try to elaborate on that in the next few slides. So what's the rationale for keeping people unaware of the treatment assignment during the trial? Is to reduce any bias that might be related to prior knowledge or beliefs about the treatment effects on the performance of the trial, not who gets into the trial and who gets assigned to which group, but once they're in the trial, that everyone gets followed in the same manner. So it promotes objectivity in the data reporting. So when people are doing ad hoc reports about whether they have had an adverse event, or those types of things that come to you sort of unscheduled, will be unbiased. Or if people don't actually know what treatment they're on, so if they don't know that they're on the aspirin treatment, maybe they're not as likely to go ahead and report gastric distress. Also, it promotes objectivity in the data collection and follow-up, so that the study schedule is maintained in all treatment groups to the same degree, and not somewhat influenced by knowing what treatment assignment people are on. You might think, oh, they're on the new treatment, so we better get them in more often and make sure they don't miss visits. So if we mask the treatments, people shouldn't be influenced by that. Also, on the other treatments people may be receiving, and the tests they receive during the trial, and even their own individual behaviors. if we mask the treatments, we're more likely to have those kind of external forces outside of the trial be the same. Because you can imagine someone who's about to enroll in a clinical trial may be more energized to change other factors in their life that would affect their treatment. Like if you were going to enroll in a trial of hypertension, well, you might decide to make some dietary modifications because now, you're more knowledgeable about hypertension and the staff has gotten you educated on the things you can do. And if you were randomized to the placebo or the control group, let's say if it was unmasked, so it's just a control group, you're going to be on observation, you might still be energized to change your lifestyle some. It also promotes objectivity in outcome assessment and in data interpretation. And by data interpretation, I'm meaning data interpretation as we go through the trial and monitor it. Certainly at the end of the trial, we're going to want to know what the treatment assignments are. So what are the levels of masking? Well, there can be many, but I'm going to just go over these three. Normally, when we're talking about a single masked trial, we're talking about a trial where the participant is masked to the treatment, but everyone else knows what the treatment is. In a double masked trial, it's usually the participant and the clinical investigators are masked to treatment. So the people administering the treatment and perhaps the same ones who are evaluating the participants' outcomes are also masked. In a triple masked trial, that can mean that the participant and the clinical investigator and others are masked to the trial. And those others might be independent people who evaluate outcomes. Let's say if there are some sort of x-rays or MRIs that need to be evaluated, that those people are also masked, or the data analysts are masked, so they just know that there's treatment group A and there's treatment group B, but they don't know which is which, or the data monitoring committee or the sponsors. So what are the advantages and disadvantages of masking? Well, I think I've just gone over the advantages so that we're protecting against performance and reporting bias. But what are the disadvantages? Why wouldn't we do this if it's a good tool to help us have more objective results? Well, the disadvantages include that it may be logistically or ethically impossible to do the masking, and we'll talk about that in a few slides when we talk about decisions to mask. It also may not reflect the clinical care practices as well, or the real-world clinical conditions where people know what treatments they're on and their healthcare providers know what treatments they're on. That may not be as real-world scenario. And it certainly increases the logistical complexity of mounting a trial and getting the treatments together. And with that increased complexity, you can imagine that also goes along with increased cost. So I just want to go over how the level of masking is related to the bias protection we get from masking. So if we don't have any masking, we do have the potential for bias in all of those areas that are listed as rows: data, reporting, collection, follow-up, and so on. Now, if we have a single mask trial where the participants mask, well, we have some protection against data reporting bias, that patients are not maybe more likely to report specific adverse events if they don't know what treatment they're on. But again, maybe not any protection for data collection and follow-up. We may be able to protect somewhat against differential behaviors in the treatment groups, but all the other concomitant things that go along with healthcare would not be masked. And you can see once we jump up to double masking, we get a lot more protection from masking, because we are actually not only masking the participant, but we're masking the people who are actually conducting the trial and evaluating the outcomes. So there's a big gain from going from single masking to double masking. And triple masking is, again, when we have other people who are involved in the data analysis and interpretation masked to the trial as we go on. And that's a little bit controversial, whether it's really good to have everybody masked in a clinical trial where you're giving people drugs and you're following their health outcomes. Somebody's got to know what's going on to protect the participants against undue risk. So how do we decide whether we're going to mask treatments in a clinical trial? I've certainly been involved in a number of trials that are unmasked trials, and I still think that they were good trials that added to the scientific evidence about treatment. But the first decision point is whether it's ethical to mask a trial. Is masking the trial going to expose participants to risks by giving them some sort of placebo treatment, a sham surgery, or an IV infusion? In some cases, those may be appropriate and okay, but you have to think about that. And in most cases, sham surgery is probably not considered appropriate. Also, even if there isn't a risk associated with giving the person a sham or placebo treatment, the risk to the participant could be increased because the investigator and caregivers don't know the treatment, and they may need to know the treatment to really appropriately ensure that the patient is protected against undue risks. So maybe because of the monitoring for the adverse events. So in that case, it would be difficult to mask. And you also have to have a viable unmasking plan. If you're going to put people in an experimental situation and not only randomizing them to treatment, you're not telling the treatment to the participants and the care providers and the clinical personnel, you've got to have a viable plan to unmask the treatment that is kind of commiserate or with the risk involved. And I'll talk about those unmasking plans. So the next thing you have to think about, is it possible to mask the treatment? Is the treatment has such distinctive characteristics that it's just impossible to mask? One treatment that's difficult to mask is zinc supplementation because there's a very characteristic flavor with zinc. And then behavioral interventions like weight loss programs and education programs, you just cannot mask. It just wouldn't work. And also maybe some community interventions. So if you're doing interventions based on at the community level, it may also be impossible to mask. And then in terms of what's possible, can you make treatments that seem identical? So this is kind of related to does the treatment have distinctive characteristics? Can you make a placebo treatment that looks exactly like the active treatment? Or in the case when you may be comparing two active treatments, can you create a placebo for each treatment so that you have a dummy treatment? So patients who are randomized to either one active treatment versus another will actually take 2 doses of medication maybe. They'll take the active treatment and then the dummy for the other treatment because you couldn't get them to look exactly alike. Also influencing whether you decide to mask is the type of outcomes you have chosen for your trial. What are the primary outcomes? If they're very objective outcomes, it's probably less important to mask. Certainly, the most objective outcome is whether a participant is alive or dead. And in that situation, it's not as likely to be influenced by people's opinions about the treatment. So the more subjective the outcome, the more you should be thinking about trying to mask the treatment. So if you're asking for patients' evaluation of how they feel, certainly in pain studies, it's very important to mask. But sometimes, even when the outcome can be fairly subjective, you may not need to mask, or you can maybe institute some bias control without masking the participants by masking the people that evaluate the outcome. So the people that are looking at the x-rays or the MRIs don't know the treatment assignment, so they won't be influenced. I've done a lot of ophthalmology studies where we've taken different images of the eye, the retina, and we haven't been able to mask a number of those studies because of the invasiveness and the different modes of treatments. You know, in some cases we had surgery where we put medicine in people's eyes. But even though we weren't able to mask the treatment at the level of the participant or the clinical investigator applying the treatment, we were able to mask the reading center that looked at the images and evaluated how the treatment was doing. So it's also another thing to think about is, what is the comparison group? Is it a no treatment observation or an active control? If you're giving someone an active treatment, you create some expectation about that this will help them. So it may be less important if you're comparing 2 active treatments to mask than if you're comparing an active treatment to no treatment, because in the no treatment group, people know they're not getting treatment, and there's some meaning to just getting treatment that may help people have better outcomes. Certainly, you have to think about whether it's feasible, what's the cost of masking, what's the benefit, are you going to be able to do it effectively enough to be worth the cost, and is it practical? Sometimes you're requiring participants to take multiple doses of medication in these kind of double dummy designs. And so are participants going to adhere to it? You know, it's hard enough to get people to take a pill each day, much less have them take 4. And you really have to think about the practicality of it. So as I said, in considering the ethics of masking, you have to have an unmasking plan if you do mask a trial. And there's 2 types of unmasking that comes up. There's the unmasking that's planned when the participant is completed the trial. You certainly want to let them know what treatment they were on, especially if they may want to continue with that treatment if they felt that they were doing well. And so this slide goes over that kind of unmasking. And the strategy depends on the closeout design. So you can have a common closeout design when you may enroll patients over a period of time, but you're going to follow everybody to a common closeout within, let's say, you may enroll unmasking. And the strategy depends on the closeout design. So you can have a common closeout design when you may enroll patients over a period of time, but you're going to follow everybody to a common closeout within, let's say, a month. So people may have different amounts of follow-up time depending on when they were enrolled in the trial, but the trial is going to end in November of 2010 regardless. So at that, you can sort of plan to shut down all operations in terms of actively following people, and you can have a closeout visit and sort of inform everyone around the same time. But more commonly, we have anniversary closeout, where participants enroll in a trial and are followed for specific specific length of time, let's say for 6 months. So you may be enrolling for a trial over a few years, but then each participant is only followed for 6 months. So you have people finishing the trial as you continue to enroll. So that's a little more difficult because you don't want to be revealing the treatment assignment to the clinic staff in a double mask trial, but you do have an obligation to reveal it to the participant. So things we've used is letters to participants at the exit interview, that we also have a letter that goes to their study physician in the asthma trials I've been involved in, and with instructions on how to continue the treatment if they were pleased with it. Also, in terms of unmasking, you should plan to find out information on what the participant and the clinical personnel thought the treatment assignment was before you reveal it. It can be informative about how effective your masking regimen was. And it's important that you document the procedure and that you provide the participant and their primary care providers with as much information as you can about their status at the end of the trial. It may be things like giving them the results of tests that were done during the trial. But then you can also have unplanned unmasking, and that's when a participant is going along in the trial and some event happens that there's a need to know what that participant is on. Commonly, you would think of it as being an adverse event. Well, the first thing is that we discourage that. We really don't want to reveal treatment assignments, and most of the time, if someone has an adverse event, you're going to stop the drug regardless of whatever else has happened. So the treatment is going to be to stop the drug and see if the adverse event goes away, and you don't really need to unmask people for that. But there can be extenuating circumstances, especially if all the treatments are approved. Well, you may need to know what the patient did poorly on to decide what the next treatment should be, and certainly in cases of overdoses where there may be real safety concerns away, and you don't really need to unmask people for that. But there are else you really don't want to what that participant is on. Commonly, you would think when a tests that were done during the trial. But then you can also have unplanned unmasking, and that's when a participant is going along in the trial and some event happens that there's a need to know what that participant is on. Commonly, you would think of it as being an adverse event. Well, the first thing is that we discourage that. We really don't want to reveal treatment assignments, and most of the time, if someone has an adverse event, you're going to stop the drug regardless of whatever else has happened. So the treatment is going to be to stop the drug and see if the adverse event goes away, and you don't really need to unmask people for that. But there can be extenuating circumstances, especially if all the treatments are approved. Well, you may need to know what the patient did poorly on to decide what the next treatment should be. And certainly in cases of overdoses where there may be real safety concerns, and then you might need to know exactly what the treatment is. If the 2-year-old has gotten the bottle open and downed 12 pills, you want to know the difference between the sugar pills and the active substance. And so you want to have easy access that is appropriate to the level of risk associated with the treatments without being too easy. So methods we've used are, if it's a lot of concern about people being able to know immediately, you could actually have the unmasking on the study drug container, something that they could pull off to reveal what's inside the bottle. And that would seem to work for most overdose situations. You'd hope the bottle would be near the 2-year-old. You can have people at the clinics who are semi-independent and from the trial and be responsible for it. You can contact the parties that are doing the randomization scheduled, so you have some sort of 24-hour call line or a website to be able to reveal the treatment assignment. And we have used all of those. And the best thing has been to discourage it. There have been very few cases where we've really had to unmask people.
The overall goal of the following experiment